Thank you.
Thank you very much. Thank you also, Professor Salmon, for the invitation. Dear colleagues, so I'll be talking about neurocognitive and neurological symptoms in post-COVID, and about one of the randomized clinical trials that we're doing in Geneva, Switzerland. So you've heard about this a lot in the past few days. It is important, however, to say that post-COVID is still something that patients who suffer from it are still suffering 3 years on, with a gradient of fatigue, which could be reported fatigue, but also could be post-exertional malaise or criteria for chronic fatigue syndrome. And so it is very important to keep talking about post-COVID and to try to find solutions and even to try to understand what are the underlying mechanisms. And so fatigue for us is a neurocognitive symptom. It is a neurological symptom. Fatigue is very vague. It can be neurologic. It can be due to other causes as well. But post-COVID fatigue is most likely due to neurological symptoms. And why is this important? Again, because there is, as some of my colleagues mentioned it in previous lectures, there is a real impact on functional capacity. And so in this study that we had conducted in Geneva, we had shown that patients who had what we call the chronification of symptoms, so patients who had long COVID, but that lasted at least 15 months, had really significant functional impairment and more visits to the primary care doctor, more utilization of healthcare, more visits to also specialists in the emergency room. So what this means is that there's a cost to the individual, to their health, to their functional capacity, but also a cost to the society as a whole. So it's not only a person's problem or disease, it's also a public health issue that needs to be explored further. And so, as you know, and as has been discussed, the symptoms can range widely from fatigue, headache, difficulty concentrating, sleep disorders, dyspnea, cough, dizziness, tinnitus, and pain. So a lot of these symptoms are actually neurological symptoms or neurocognitive symptoms. Fatigue, as we mentioned, headache, difficulty concentrating. Sleep is also related to neurological symptoms. Pain is mostly neuropathic pain that we see, we have a study going on at the Geneva University Hospital, also biopsying areas where there is this neuropathic pain, and we are finding that there is some small fiber pathology. So there could be some underlying mechanisms for these neuropathic pains. And so what we know today, we have tried to disseminate or to diffuse to the general population. So in Geneva, Switzerland, where I work currently at the Geneva University Hospital, with 17 different partners all over Europe, but also in Canada and mostly in the Francophone world, we tried to put a system or a platform online for bidirectional exchange. It started early on, and it's called Raphael. It's a platform where we have information on post-COVID management, social impact, and we also did this platform for adults and for children, adolescents, and because it was important for us to see what were the questions or what were the things that were preoccupying patients, their parents, their families, but also healthcare professionals. So Raphael started as this platform for bidirectional exchange. There's also a chatbot where people can ask questions and get answers, and also a community moderator if the chatbot doesn't know how to answer. And we hope that Raphael, we initially started doing literature review where we would put all the ongoing clinical trials on there, and we would hope with coordination and collaboration with other sites, partners, and also other investigators to actually transform it even into a platform where we can announce what are the ongoing clinical trials and have patients participate if they fill the profile, if they live close by, or if they have the inclusion criteria. It's important to have such platforms. There's Après G20 also in France. There are other platforms because it's important for patients to communicate together with healthcare professionals, and also because we are still learning about this disease. The idea was also that maybe some part of post-COVID or symptoms can be handled with self-management options on the long run. Not all of them, but some of them, including pacing, other resources that we've put online on the platform, like breathing exercises, hypnosis, meditation, and Tai Chi. All these resources help with whether vagal nerve stimulation, but also neurocognitive symptoms in general. And so the idea was really to give the opportunity for patients and for healthcare professionals to have this information online and to manage their symptoms at home, if possible. And so I do invite you to look at these resources. They're in French, but they are quite helpful because they really look at symptoms in a broad sense. And these exercises or therapies can help not only long COVID patients, but also the general state of health. And so my main talk will be about this RCT that we're doing in Geneva. It's not only in Geneva, it's a multi-site, it's probably one of the first European multi-site studies that is still ongoing with sites in Spain, Italy, and in Switzerland. So in Switzerland, we have the 5 sites, Geneva being the primary investigator site, but also Bern, Basel, Sion, and Chur. This RCT is for patients who have fatigue or neurocognitive symptoms, and I'll be talking about the hypothesis behind it and what kind of treatment we are trying to study or evaluate, completing also what Professor Salmon had said earlier about the study. So why this study and what is the hypothesis behind it? Maybe some of you know, we do have retroviruses in our DNA. About 8% of our DNA is actually composed of retroviruses. Retroviruses are usually, so they're endogenous, and usually they're not activated. And sometimes there's a virus that can come, and that could be COVID, SARS-CoV-2, it can be EBV, CMV, or other viruses, or some kind of pathogen, actually, that may activate these retroviruses. And so knowing that these retroviruses should not be activated, once they're activated, this becomes pathologic. And so the idea is to try to stop this activation loop. So like I said, when you have any virus, it can activate in certain individuals, not all of them, this activation loop, and the idea would be to actually try to stop this activation loop. And so this is the hypothesis behind the randomized control trial that we're conducting in Geneva and in other sites in Europe as well. So SARS-CoV-2 has been shown actually to be associated with an increased expression of WONV or HERV protein. This HERV protein or WONV is actually expressed by retroviruses. So again, retroviruses should not be activated. If they are activated, they are pathologic and they can produce products or molecules. And one of these molecules is WONV or HERV. It's from the HERV family. And so we now know that SARS-CoV-2 in some studies was associated with an increased expression of HERV or WONV. We also know that WONV or HERV is associated with, has some pro-inflammatory actually properties, and is associated with symptoms such as fatigue and neurocognitive symptoms. This was shown in other diseases as well, such as multiple sclerosis or amyotrophic lateral sclerosis. And so if we follow this chain, we have a virus that can activate a retrovirus that will express a WONV or pathologic protein, and this protein is associated with neurocognitive symptoms. And so the idea is to stop this WONV production or try to reduce it as much as possible. And this is where there's a monoclonal antibody that is in a phase 2 trial currently, which is tumelimab, and this monoclonal antibody has been studied in in multiple sclerosis and in ALS. It has not been studied yet in post-COVID. This is what we're doing, actually. And the idea is to target the WONV or the HERV protein to reduce its activity or even its existence so that we have less, hopefully less, pro-inflammatory properties and less neurocognitive symptoms. So this is a traditional PICO that kind of describes our study. We have in the population, it's adults who are 18 years of age or more who have a SARS-CoV-2 infection. Unfortunately or fortunately, we have to have some kind of documentation of SARS-CoV-2 infection, meaning that an antigen test, antibodies, anti-N antibodies with a medical certificate saying that this patient has post-COVID symptoms are also accepted, and obviously the PCR tests as well. And so in accordance with the NICE criteria from the UK, one of the inclusion criteria is to have symptoms that have been ongoing for more than 12 weeks. And the symptoms that we're looking for are fatigue and neurocognitive symptoms. And so the intervention is to give tumelimab, and I'll show you how. And then the comparison is a placebo, double-blinded, obviously, over 24 weeks or 6 infusions. And the primary outcome is actually improvement in fatigue. And here, and this is the challenge, I think, in a lot of RCTs and a lot of studies that will be happening on post-COVID, is that how do you get hard outcomes, which what we call hard outcomes in science, is some kind of objective measure, which is still to be discovered or to be better defined in post-COVID. So here it's a decrease in fatigue. Fatigue is self-reported using the PROMIS 7A scale, but it is self-reported. So there could be also some variability depending on how the person feels that day, and or subjectively how the person would evaluate their fatigue. We do have several secondary endpoints, one of them being actually the reduction of WONV protein in the blood, but also the severity of symptoms, other symptoms, functional impairment, quality of life, and safety outcomes. So again, these are the inclusion criteria: adults with a history of SARS-CoV-2 infection, symptoms that are persisting for more than 12 weeks. We do a first screening visit where we have to identify WONV protein. So some of you might be wondering what is the prevalence of WONV protein in post-COVID in general, and what we find, and what we found from other cohorts, is that it's about 30% of post-COVID patients who might have the WONV protein, meaning that it's not the only explanation for post-COVID symptoms. It might be one of the explanations. The study still has to be analyzed and completed. But what's important is to continue doing these randomized controlled trials and these trials to try to get some kind of answer. But that being said, so the inclusion criteria is to have the WONV or HERV protein, and that's in 30% of patients who have post-COVID. Unfortunately, we can't include the other 70%, and other clinical trials have to be done and conducted to be able to find other potential mechanisms in this probably multifactorial disease. Fatigue with a score of more than 21 on the PROMIS scale is also important as an inclusion criteria. And then we had defined some secondary scales that look into quality of life, so the Euroqual 5D5L, the PQD, which is the perceived questionnaire deficit, which has to be more than 27, and the token motor test, which is a neuropsychological test, actually, which has to be positive as well. And so this is what happens at the screening period. We have first the identification of the protein, and confirmation of all the inclusion criteria. We also do some blood tests to make sure that we don't have other diseases, just like in any other randomized control trial. It is important to make sure that we don't have immunosuppressed participants, for example, or any kind of disease where having a medication that has not yet been fully evaluated might put the participants at risk. And so this is part of the screening period that we do over the first 2 to 3 weeks. And then every 4 weeks, the participant will come to the clinical site, and they will receive either temelimab, or which is a monoclonal antibody, or a placebo, once every 4 weeks for 6 months or 24 weeks. And so participants will receive a total of 6 infusions, and the objective was to recruit 200 participants, which has been possible thanks to all the sites actually that participated, and thanks to actually even funding from the Federal Office of Public Health for this study, which was also important. And right now, what we're doing is trying to evaluate. So the study is still ongoing in the sense that we have recruited all patients, participants. The recruitment ended in the beginning of November, or November 7, actually. And so now, if the last participant was recruited on November 7, we have to count at least 6 months for them to finish their participation, and then we will have the results or the analysis. And so as fast as science and research is moving, or we would hope it moves, especially in long COVID, because again, there's the impact on the functional capacity on the individual and on public health in general, it might not be fast enough for patients who are suffering from long COVID, because if we look at the timeline, the symptoms might have started in March 2020. We started the RCT in August 2022. And then we won't have the results before August 2024. So that's 4 years of symptoms or long COVID, and knowing that it might not be the only solution and the only answer to post-COVID symptoms. And so one of the lessons that we've learned, and that we really encourage other researchers, but also stakeholders to do, is to contribute to research and to science. This is the only way where every year we can come back and have more information about this disease and how to help patients. We were discussing this with Professor Salmon just now, and I love your positive attitude, actually, which is great, because it's true that, we started together back in 2020, and at a time when people were still probably suggesting, exercise-graded therapy or things that are contraindicated now. Since then, we've moved to make sure that patients are taken care of, and that we do pacing. And some molecules, like Professor Salmon was mentioning, like beta blockers, ivabradine, or antihistamines, were being given, but there was not enough evidence. And so now we have these randomized controlled trials that are looking into these molecules and these medications, and we have ongoing or new clinical trials like the temelimab one, and other clinical trials in the UK and everywhere in the world. I do invite you actually to look on the Raphael platform, because we have a document where we try to summarize all the ongoing clinical trials, where they're happening, and when we should expect results. And so hopefully that with time, we will continue having more and more results, and every year or every couple of months, we can come back with better answers. So this is it for me. Thank you very much. I'm happy to have you.